Welcome to the American College of Surgeons Bulletin Brief from the front line, Surgeons' Voices. With me today is my friend and fellow Regent, Dr. Douglas Wood. Dr. Wood is the Henry N. Harkins Professor and Chair of the Department of Surgery at the University of Washington. Welcome, Doug.
Thanks so much, Steve. It's great to be here. I always enjoy being interviewed by you.
Well, thanks. I enjoy interviewing you and enjoy interacting with you at the Board of Regents as well, very much. Today, we're going to talk specifically about an excellent piece which you had written in the Journal of Thoracic Disease entitled How Men Can Be Good Allies for Women in Surgery, He for She. Now, for those people who are not on Twitter, I paused there before saying hashtag He for She, which is perhaps the subject of another interview. Those on Twitter will immediately recognize the hashtag He for She. So I'm glad you incorporated it in the title of your article. Could you first tell us what was the impetus for writing this article?
Yes, well, a couple of things. The subject of my presidential address to the Society of Thoracic Surgeons now 7 years ago was about this issue. Because particularly in cardiothoracic surgery, women are sorely underrepresented. At the time that I gave that address, 6% of cardiothoracic surgeons were women, and I made it the major subject of my address. And colleagues of mine, Dr. Cecilia Pompili and Dr. Leah Bacchus, were putting together a whole journal issue on women in thoracic surgery. It's a fantastic issue that was just published in the Journal of Thoracic Disease and has multiple articles that covers multiple aspects in different continents and different aspects of women in cardiothoracic surgery. And I was honored and fortunate that they invited me to contribute to that and give a male perspective, in this case, hashtag He for She.
I understand that you had made some impact as president of STS because between your term 7 years ago and now, the percentage increased. Your article stated 10%, which by no means is where I'm sure you'd like to be or should be, but it was a bit of an increase. So people must have heeded your message. I'm sure there's a bit of a lag time as well. But can you tell us about some of the facets within the article? For example, two main themes that you covered were microaggression, perhaps we'll come to that one second in the order in which you had them in the paper, and the other one was sexual harassment. So maybe we'll take them in the order in which you wrote about them and first address the sexual harassment theme.
I think we'd like to think that sexual harassment doesn't occur. As a male, it's easy to overlook, but indeed it does occur. It's rampant. Actually, there was a survey done by the American College of Surgeons not long ago that showed that over 50% of women in surgery had suffered some form of sexual harassment in the previous 12 months, not just ever, but in the previous 12 months. We often think of sexual harassment in its most severe form, that is, actual invitations for sex or quid pro quo for different aspects of favoritism. But there's a whole nother level that's more insidious and more probably constantly present that our women colleagues could definitely educate us about. Things that relate to a hostile environment, the type of stories that are told, the type of banter that exists amongst men, sort of a locker room culture that can occur when it's a male-dominated specialty, and multiple aspects of comments on dress, appearance, weight, things that men don't get comments about, but women do. And it's another form of sexual harassment. One of the issues is that it creates kind of an environment where women have to navigate that men don't in general, that women have to thread the needle of trying to maintain relationships with a lot of male peers and yet try to avoid the aspects of sexual innuendo or sexual invitation. It's a form of gender tax that women have of being women in a specialty dominated by men. I'm always learning from the women I work with. And one of the things I learned not that long ago is there's actually some data about the percentage of women necessary to kind of change the culture of a male-dominated environment. And it's about a third. But when you get to a third of women in the environment, it changes the culture and makes it a much more gender neutral culture rather than a male dominated culture.
Well, I think that I can attest to that in my specialty in colorectal surgery, in that I believe our applicant pool is roughly the same proportional representation as in med school, roughly 50%. We have 5 ACGM accredited trainees in our program every year. Some year there's 2, some years 3, we've had 4. So I guess the average probably is somewhere between a third and a half, as well as on our staff. I'm curious, although it wasn't the focus of your article, why do you think that, in the 7 years since your presidency, it only went from 6 to 10%, which clearly isn't where we need it to be compared to colorectal surgery that is probably about 50%?
Well, I see, going from 6% women to 10% women is both a victory and a failure. It's a victory because it's about a 70% improvement. So you'd say, well, that's actually pretty good if you look at percent improvement, and then you look at 10% and say that's woefully inadequate. One of the main points I make is cardiothoracic surgery is missing half of the talent pool if we're not attracting women into the specialty at equal rates of men. Fortunately, the pipeline looks much more favorable than what the reality is of practicing surgeons. So we're continuing to make progress, but that progress really needs to be accelerated, because if it goes at just a organic level, it's going to take a long time to get to 50-50. And I hope we can speed that up and be much more like you're describing colorectal surgery.
Yeah, I certainly hope so, because I guess you're right. When you look at the failure aspect, the other point is if you think about 4% over 7 years, it's roughly 0.5% a year, which isn't going to get you to 50% too quickly. And I'm sure, with you being at the top of this very important subject, that will happen. You'll think of some plans, but in the short time of the interview, I don't think we're going to be able to go into how the thoracic surgery world is going to solve that problem. But I would like to carry on the theme of your paper, and microaggression was the next major aspect you covered, and I'm not necessarily sure everybody is familiar with the term, and perhaps you could give us some examples.
Well, I think, by now we've all heard of microaggressions, and in some ways all of us suffer from them, but any marginalized group suffers from them disproportionately. In this case, in surgery, and certainly in cardiothoracic surgery, women suffer from microaggressions, and they can come in a variety of forms. And one of the things that's useful is just to call them out, to know what they are. So, because I think the problem is the fact that they're micro means that men don't recognize them unless they've been called out. It is things like talking over women in a committee meeting. It is things like introducing you and me as Dr. Wexner and Dr. Wood, and in the same line, using a first name introduction to a woman who's a surgeon peer. It can be things like comments about gender differences in ability. And there are biases that we have of whether women are good surgeons or whether they have the work ethic of men. So these kind of comments in committee meetings, in closed environments, and discussions about candidates or peers, those are all cuts. And microaggressions results in death by 1,000 cuts. And they're aspects that women surgeons really deal with, I think, probably on a virtual daily basis.
Interesting. I must say that one of the benefits of us having the workforce at roughly 50% is I found the women, if anyway, my bias is the other way, because the women are sort of uniformly, and I've had one of your alumni is now one of my alumni, the women are uniformly really, really good, and the men are variably really, really good. And that's my own bias at this point in time, having been exposed to such a large number of trainees. So I look forward to the day when you guys in cardiothoracic surgery get to that same point of the roughly 50-50. In your paper, you had 2, I thought, very helpful tables on do's and don'ts. One table was on do's and don'ts for male surgery residents and early career faculty, and the other on do's and don'ts for male senior surgeons and leaders. And perhaps you could review a few of those points with us.
They relate to the fact that men need to stand up for women, particularly when women are a minority. But I'd say even when they're not a minority, we need to be allies, allies for each other. Women are allies for me, and I want to be an ally for the women I am with. And being an ally means being alert to microaggressions or macroaggressions. I think first talking about sexual harassment, which we discussed first, and doing one of multiple things. So there might be times that it simply requires noticing and being a friend and colleague to the woman that has suffered a microaggression. It might not necessarily be something that she wants you to speak up about, but acknowledging and noting that you saw what happened and you heard it and you're in solidarity with them. That's being a friend, it's being a colleague. But there are other times that it might be useful to speak up in a meeting when someone starts to talk over a woman. Redirect the conversation back to the woman and ask them, what was the point that you were trying to make? We're often trying to not create any conflict, but you can easily move around somebody that speaks up over a woman and redirect that conversation back to her. If someone formally introduces a woman surgeon by her first name, respond by using her formal title and recognize her as a doctor. If you see places where women might be threatened in terms of sexual commentary, harassment, note it, speak up in the moment, but also talk with them on the side and say, I noticed this, how can I help you? Is it something that I can support you with officially, or is it something that you'd like to talk about? So there are lots of ways that men can be allies for women in kind of the day-to-day interactions that we have.
There was one term you used that I thought was particularly interesting, mansplain. I'm not sure that's a ubiquitous term. Maybe it is. I just have heard it, but perhaps you could explain that one to us.
Well, I'm in a household of women. Besides my wife, I have two very strong daughters. And mansplaining means that if I'm at the dinner table and I'm holding court on something that I think that I know a lot about, I'm mansplaining to the usually more intelligent women that I'm around. And it turns out men do tend to do that, particularly in aspects that are professional, but also things that then go beyond professional. You know, we mansplain about sports or cars or whatever we might think that we're experts in. That's a microaggression as well. And I'd say recognize it. And I mean, I know I do it. I'm trying to now be aware and be quiet when a woman that I'm with knows just as much or more than I do.
I think that is very, very sage advice. And again, with you at the helm and hopefully getting many other men engaged in thoracic surgery, you'll fix the problem and reach parity in terms of workforce distribution, which will benefit the workforce and it'll benefit patients, obviously. People working with the cardiothoracic surgeons. As I already know you do it in your department and are a huge staunch advocate at the ACS. Maybe we can also take this opportunity just to put in a pitch for the Twitter hashtag, the He for She campaign. I don't know if you want to just mention that as our last informational point.
Well, yeah, I'll make maybe just a last comment about that. I've been talking about being an ally, but I'd say men should also be a sponsor for women. So this is where that's different than being a mentor. Being a sponsor means thinking about them for a committee assignment, for a panel, for a leadership position in our specialty organizations or in your hospital or department. Actively promoting women into leadership positions is part of our responsibility as well, because often men are in the position of power and the position of being able to be a good sponsor. And I guess that relates to hashtag he for she. Men, particularly in a specialty like cardiothoracic surgery that's dominantly male, have an outsized role in advancing, recruiting, retaining, and promoting women. And that's what hashtag he for she stands for, is really men standing up and supporting the women colleagues that they work beside every day.
Well, thanks very much. I really enjoyed your article. I thought the way that you succinctly had your two tables was an excellent way to just kind of summarize what was in there, very practical and implementable points. And part of what you said that I think people should really take home, all of it, of course, but just be aware, right? Be conscious. That's the beginning, isn't it?
Yeah, just having awareness of these issues, I think, goes a long way towards mitigating what I think is generally unintended slights that men make. Some of them are intended, but I think most don't want to offend or have microaggressions. So being aware, knowing that we're vulnerable and that we make mistakes and just trying to be better, that's all steps towards having a better environment for us to rise the boat for all of us to have more successful careers and more successful profession.
Which is absolutely essential. I'll recognize a problem, you can't begin to fix it. So it's essential the problem is recognized, working to fix it. Thank you for this excellent article. Thanks for your time today in the interview, and wishing you sustained health. We'll hopefully see each other in person at some point in the not too distant future.
Thank you, Steve. Really appreciate being included.